Hi, well, thank you so much for having me do this. This is a big passion of mine, and don't let my title get in the way of understanding that I have not been medical director of this program for very long. It is part of my evolution as a teacher in rural medicine. First and foremost, I am a family physician doing full scope family medicine. I stopped doing OB about 10 years ago in rural Western New York, in Yates County in the Finger Lakes area. And my position as medical director of this program evolved from my joy in teaching and continued involvement in the program for many years. This is just a road
you
outside
download
of town.
the map on your phone.
So this is the background. When I was an intern, I noticed I really enjoyed teaching medical students in our family practice program in a large community hospital in Syracuse. By the time I was a senior resident, I realized that I really, really loved it. But first and foremost, I wanted to be a country doctor. And like with a lot of things in life, there are trade-offs. And I thought the trade-off would be that I wouldn't be able to be heavily immersed in teaching. In other words, that it wouldn't be part of my everyday life once I started my rural practice after I took over from the retiring GP 33 plus years ago. I had occasional students, local folks who wanted to do a rotation. The Rochester Medical School would occasionally send somebody out for a short stint as an elective or part of their sort of early medical school years clinical exposure. And then about 24 years ago, Syracuse's RMed, which is a not quite a longitudinal full track program, reached out to me. I mean, I'd been there in Syracuse to see if I would be one of their preceptors. At that time, RMed was a 9-month program where after doing the basic medicine, pediatric psychiatry clinical time at the main university, they moved out to a rural town somewhere in upstate New York and spent 9 months roughly doing half-time longitudinally with a primary preceptor in family medicine and half-time rotating through various electives and subspecialties. The program's evolved over the years. It's a little different now to meet the demands of modern medical education and students' preferences. But at a minimum, they spend a 5-month period living in a community, immersed in the community, doing their family medicine clerkship, their general surgery clerkship, and their emergency room clerkship, and some elective time. We have lots of opportunities to expand that, including an AI that I recently built. So that's where we're at now, and this gives you some background. And I think an example of, especially for the younger participants today, the students and younger participants, how this can grow and evolve over your career. And then again, to my delight, being a teacher and an educator is a central part of what I do every day, even though I'm in a small rural practice. This is where I am. That's Yates County. It's a little very sparsely populated county in the Finger Lakes, some tourism and largely agricultural. We, in the last 20 years, have gotten a fairly good-sized Pennsylvania Dutch Old Order Mennonite population that's moved up to take advantage of farmland for sale and good soil. So the title of this is A Day in the Life of. I've got to figure out how to get my pictures off here. I think I have to minimize them, so let me just make a click there so I can read my own slides. Okay, there we go. So this is a typical day. I round in the morning, typically ask my student to be there half an hour before and work on patients that he's been seeing with me. I usually assign them 1 or 2. So 8 o'clock, I get to the hospital and meet him on the medical surge floor and we review the chart and see our patient who's in with a COPD exacerbation. He started a note, and as I mentioned, that can now be used as part of my documentation as long as I do all the key portions myself. I have him present the patient in the usual fashion that we were all taught. This is, this is the subjective, objective, and so on. And so we get to the next point, and actually our system has now been upgraded so they can enter provisional orders, which is, I think, a very important teaching feature for the following reason. So I asked him what should we do today for our patient who's doing better? And his answer is, I think we should transition to oral steroids. And it's the standard medical student answer, but it doesn't do beans as a nurse, as an order for the nursing staff or the hospital staff. So I answer, is that what you're going to write? Transition to oral steroids. And that gets them thinking to the next level. And I think it brings on a sense of competence and capability and feeling like they're beginning to be a physician and not just a student. After that, we head to the nursery. There was a baby born overnight, and we do the initial visit. I observe in the exam a nice healthy baby, fortunately, but ask, why are we doing red reflex? What if you heard a murmur in a 1-day-old? What would you think about? What if there was a positive ortolani? And all those things, even in a normal patient, can be teaching points, because sometimes you're going to find abnormals and sometimes not. And there's a lot to talk about, as you know, with any three of those topics. Before we head out the door, we pop on the computer and look at the Idi Census. Unfortunately, nobody's there. And back to the office we head. We get back to the office, and this patient, this student rather, tells me, in the 2 weeks I've been here doing family medicine, I've done more newborn exams and taught more about newborn exams and done more outpatient GYN than in my entire pediatric clerkship and in my entire OBGYN clerkship. And I think that has a message maybe for all of us today. This is a Mennonite schoolhouse outside of town. They are kind of scattered around the area because they don't have very many students per. So anyway, we get to the office about 9:40, and our first patient on a rounding week, we rotate our rounds among partners. Our first patient is at 10 o'clock, and that's mine, because we have to figure out how to maintain a schedule while we're teaching. So I take the first one, plan to take the first one. We look at the schedule together and make some notes about what ones might be good for her to see. I'm switching from him to her because I'm talking with this year's student now. Bearing in mind that we're going to have some acutes added to the schedule, and I'm not going to book her right up with what I think is a reasonable day's work for the student, because the acutes are pretty important too. So I take the first one myself, have her prepare for the second one by reviewing the chart. She typically would start a note and make some comments in the subjective section about things she wanted to ask about, so she could fill that in as she was talking with the patient. And usually the patients, we ask them to be there before their appointment. My nurse will have roomed them and she can get started. So she sees a 91-year-old retired medical engineer for his 6-month chronic condition visit. From outside the room, I hear them laughing and conversing, which I get a big kick out of. I love having my 90-somethings, my World War II vets, have an opportunity to talk with these students, because it's something, they're going to be able to tell their grandchildren someday that I knew somebody who fought in the Battle of the Bulge. This particular individual didn't, but I have another fellow who does, and he loves to see my students. So again, I have her present the case similarly to the other. He's here for a 6-month follow-up. Overall, he's feeling well. He wonders about this pain in his back, but it's et cetera, et cetera. And so after she's presented, I give the open-ended question to her: what do you want to do? And so she thinks of all the things that we might do because of all this problem list. And my answer to that is, just don't do something, stand there. I think a lot of medical students come to us in a setting where they kind of get a pat on the back or a kudo, or maybe even a little better grade if they can think of a test to order or an intervention to do that nobody else on the team has thought of. And you have to unlearn them the fact that the best thing to do sometimes is nothing. So when we're done, she says, is it possible you could have an early myeloproliferative disorder? She's prepped herself, read the chart well. and we talk about that. And, so we talk about how do you decide if you're going to do more workup or not, and whether you're worried about it. And we check, and his bite count's been that forever, which, I kind of knew. And so the teaching point number 2, I ask her if she thinks the minor anemia is significant. She says, well, it could be. I say, well, you actually know if this guy has a problem with red cell production. And she looks puzzled. And then I say, well, let's talk about his blood pressure. His blood pressure was borderline today. She says, well, I'm really not worried about it because his pressures are, and she says, oh, when we ask about a blood pressure in there, he told me he gives blood every 8 weeks. And the teaching point there is, again, it's helping students not silo their thinking by diagnosis, use every tidbit they get in the exam room, even if some of it's from the casual conversation. But clearly he didn't have a problem with erythrocyte production. My office is on the same 12 acres as my house. It's about at both ends of it, and I have this pond in the middle, and that's my son, who's also my partner, and taking advantage of living out here in the country. She goes and sees about every 3rd patient. I try to bounce it around. When they've been with me a little while with the right patient, they get to do some procedures, which is a great confidence builder and sense of competence. We talked about that in terms of as teachers, it's important to have a sense of competency. So important that young doctors start to develop that competency sense early on. She writes notes. I don't go over every note with her. That's, that would be hard. But I finish them off, but one of the teaching things I've done is I've said, you print off the way you wrote it, then print off the way I wrote it, and look at the difference. And if you want to talk about it, we can. I go home for lunch if I'm in the same office that my house is on the property of. If we're not, we talk or take a walk, or talk and take a walk, but we don't talk medicine. I think there's that's part of mentoring as a rural preceptor. This is my walk home from my office. In the afternoon, she's just finished up with a 23-year-old with a pretty straightforward sore throat. And instead of the usual presentation, I do the 5-minute preceptor thing. And some of you may have heard of this and some not. So the 5-minute preceptor is what do you want to do? So you start at the end of the visit, and you can work it backwards as far as you want to. And in this case, she says, swab his throat, and if the strep swab is positive, I'll treat with antibiotics. And you can stop there and say, good, you're right, or if she's wrong, not, or you can say, well, what was it that made you think we should do this? But this is a technique to teach on the fly that helps you stay on schedule. At the end of the day, we take 15 to 30 minutes to discuss any questions. I have her carry an index card so that we're not, getting backlogged with questions in the midst of the day's flow. But it adds time at the end of the day, of course, and I use it to give her some feedback on things over the course of the day. Just another view from here in the fall. Before I wrap up, I'm going to do just a little teaching on my own. Since I took over this medical director job, I've really made it a point to create once a year, I think, a pretty robust faculty development seminar for our community preceptors. I think it's so important, as we discussed before, and it's in the reading, that doctors who are teaching feel competent. I mean, none of us would walk in and see a patient if we didn't think we were trained to do that, and trained reasonably well. And I'm going to make a pitch that if you're a young physician especially, but if you're going to be doing some teaching, if you feel like the medical school you're teaching for isn't supporting you in this, tell them I need useful, efficient, fun training and being an excellent teacher. And honestly, our students statewide tell us that. I'm also work with the State Academy of Family Physicians. Anyway, I'm just going to zip through these bullet points real fast and get it back to Randy. And these may be surprises or not. Compliments lead to more satisfaction than specific feedback. That might be intuitive. It's actually true because compliments led to satisfaction, but didn't really improve learning very much. Performance improved for students receiving feedback. There was no change for those receiving compliments. student satisfaction is not an accurate measure of the quality of feedback. So those of us in education especially, but also teachers, need to not be overly sensitive about the student evaluation of teachers. I mean, they need to be taken seriously because there are some issues, but you know, having the student evaluate the teacher and the teacher evaluate the student, you know, has been a thing now for probably 60 years. And it turns out that student satisfaction is not necessarily a good measure of how well students learn. Learning is clearly a function of feedback, and the student may not appreciate it until years later, but we still need to educate and not worry about, you know, I mean, we shouldn't expect a young person in their formative years necessarily to appreciate that they're learning a lesson. I mean, certainly I didn't always. Basic concepts, it should be frequent. With each session, it should be focused, no more than 2 domains per conversation. Hanging on a clinical situation forever and ever. When they think of that diagnosis, they'll think of that lady, and they'll think of that teaching point and what maybe they could have done better. Specific and actionable. I mean, if you're giving feedback, you can't just say, please try to do better. They need to know what do better means, or that was awesome. Well, what specific thing was awesome? Avoid the self-esteem sandwich. This was a big popular thing for a long time, and I think a lot of us were taught it. It certainly is comfortable to say, you're amazing, but you really need to work on this, but you're still awesome. It's comfortable. It's not very effective. That's just the corner of my house. Randy, how am I doing? Do I have another couple minutes, or?
You're doing fine.
Okay. Then I'm going to run through some of these student comments. I mean, this is my, you know, I mean, you guys all read the paper by Dr. Idi Ostrander, my niece. And by the way, if anybody's interested in talking to her about either her experience or, you know, contact information for that longitudinal track at Maine, she'd be more than happy to be reached out to. Anyway, so comments from my students. In Syracuse, I felt like so much of my time was being wasted. I was just another medical student, and some services even seemed to resent my presence at all. Usually my presentations fell on deaf ears, with better attendings pretending to listen before turning to their intern to repeat the things I had just said, and worse ones cutting me off before my introduction had left my mouth. Even when I interacted with people interested in teaching me, they seemed so preoccupied and pulled in by 1,000 different directions that much of my time was spent sitting or standing quietly, waiting for them to have time for me. And this goes into the negatively transformative situation. By this point, I was the most bitter I had ever been in my life, as I am typically a very upbeat and positive person. Just from being routinely ignored, resented, and berated for months on end, without a sense of identity or purpose within the system. In our office, I found myself excited to go into the clinic in the morning, ready to be active in patient care and knowing that I would be learning so much. I've gotten to know patients and their family members and learned how physicians can truly be a pillar of the community they practice in. I have been welcomed with open arms to the point of being invited to dinner with virtual strangers. It has been a much more immersive, hands-on, interactive, and fulfilling learning experience than I ever could have dreamed of before coming here. I feel as though my short time in Canandaigua would be more formative and important to my medical education than any other time in medical school. From a student from a couple of years ago, patients are more than their diseases, so much more. I don't think I ever would have come to know that were it not for a program where I was able to learn medicine in various fields during my 3rd and 4th years of medical school in a rural setting. And this looks like it comes from a paper, but it doesn't come from a paper. It just comes from one of the other students that I said, hey, can you guys, give me some words for my webinar that I'm doing? This is last year's student, Francis students, the opportunity for more autonomy. Preceptor quickly can discern the skill level and create an appropriate level of autonomy. Students are more motivated to demonstrate growth, allows more opportunities for feedback. It's higher quality, delivered faster. It's verbal and direct, more valuable patient encounters. You just more because that's how we did it. Heightened sense of community and bonding, weekly volleyball games. He came to my wife and I play volleyball a couple nights a week, get a pickup. I have a friend who builds sailboats, dinners, lunches. An emphasis placed on working as a team in order to provide the best quality care. Fewer members on the team compared to larger institution provides opportunity for the student to pursue an accelerated rate of development. Fewer resources, conducting your own pathology, histology. I still do microscopy in my office, as I suspect many of you do. I do lots of excisions and injections and do more procedures. At their general surgery clerkship, they get the first assist instead of, fourth assist. Being more reliant on thorough and precise physical exam. And part of it's the tests are not readily available, and part of it's because us older country doctors are prone to do things that way. And I think at the medical schools, unfortunately, a lot of the students learn test first, ask questions later. I don't mean to be pejorative, but I certainly, hear that from the students. And we talk about the process, the system side, the business side of medicine, public health. The students felt like he had better chance to ask questions and get answers. And less intimidated. The attendings here are so thrilled to have somebody to teach that it doesn't sometimes have that onerous feel when you ask the lead attending on the case, who's 7 levels above you because you're working with senior residents and such. The attendings feel more like colleagues, I think. That's my backyard and my wife and my granddaughter having lunch. So this is the end of the chat here. Challenges that people cite, and they're real. I mean, they're difficult. We got to figure out how to cope with them or accept the issues. And this is what we hear from when we try to recruit community preceptors. It's what we hear from ourselves saying this is a struggle. Decreased productivity, more and more employed physicians. Almost have quotas, which can be an RVU quota, which can be frustrating. And if you're independent, you still got to pay your bills. Getting behind schedule, infringement on personal time, and I'm not going to get into my thoughts about work-life balance versus integrated life, but I'll throw that out there. Administrative tasks, lack of expertise as a teacher. We talked about that early. For older preceptors, there may be some generational differences in cultures and values. We hear that a lot with our preceptors that are my age group in their late 50s to mid 60s, that things are so different with med students these days. I think that kind of conversation has been going on in every field for as long as human beings have existed. But it can be a challenge. And the effect of frustration and burnout in the office on teaching. The last thing you want to do is make your time teaching a negative transformational experience by spending all your day conveying non-verbally and third party how frustrated you are with prior auths and the EMR and so on and so forth. So those are challenges, and people don't want to, you don't want the students to see that that's what family medicine can be or primary care. Rewards, sometimes there's a stipend. That's not usually enough to make up the difference. CME for teaching and programs at no or reduced cost, that can be a big plus. Faculty appointment is a nice feel. Networking with other preceptors, I'm about done. Creating a legacy, I think that's a big deal. And it was as big a deal to me 24 years ago when I started doing it as it is now. The learning and having your assumptions challenged, I really enjoy that because sometimes you do something because you've always done it that way, or because your professor did it that way, and have the students ask you that question and realize, I have no idea why I do that way. Let's figure out that together if it's sensible, and if not, let's teach something. Affirmation and reinvigoration. Sometimes if I go a chunk of time without a student, I forget how cool it is, the stuff we do. I mean, the interpersonal stuff in the service is great, but it's just really interesting things. And, you can reconnect with some of that excitement about the wonder of it all. And then, having the practice team and the patients become part of the teaching team. My patients love that they're teachers. So that is my final picture. That's my student from a couple years ago, and I hope one of my future colleagues at his graduation, where he asked me to hood him.